Hi, my name is Jack Crow. I'm an aortic dissection survivor, and I am an aortic athlete. And welcome to our continuing series of conversations with really world-renowned cardiologists who have a lot of experience in aortic disease and exercise. And I'm going to introduce our special guest today in a moment. But before I get to that, we've got a little bit of breaking news. Our aortic athlete friends, Dr. Alan Braverman, Dr. Tim Churchill, and Dr. Siddharth Prakash are just launching the first ever observational study of people like me who have had an aortic dissection and also have engaged in some kind of endurance athlete events. So we invite any of you who've had an aortic dissection and engage in regular exercises, including some longer aerobic activity, to apply to join this brand new study that's just coming out. And you can find details about it on our Facebook page, Aortic Athletes, and you can also hear about it on our website, aorticathletes.org. For example, we're going to be including people, if you've run longer than a 10K post-aortic dissection or biked longer than 30 miles, we are kind of in a select group. We're a little bit of pioneers, and for the first time ever, we're going to start a study. So find out more, join me, join Carmen David, our co-founder, in participating in this study. Also, I want you to click like on this video so it gets sent into the ethos to more people. And remember to join Aortic Hope, our sponsor here today, and Aortic Athletes on Facebook. Aortic Athletes now has an Instagram page. It's public. Lots of inspiring things there. These are great places to find peer-to-peer support and science-based information. And always remember, these videos are for informational purposes only. Each of us has aortic disease. With aortic disease is different. Each of us needs to discuss our exercise routine with our cardiologist. So keep that in mind today. So I'm very happy to welcome our guest, Dr. Paul Thompson. Dr. Thompson, welcome to Aortic Athletes. And Dr. Thompson is at Hartford Health in Connecticut, where he's the head of cardiology emeritus. And that only scratches the surface because he's also a renowned researcher in cardiovascular disease, especially with athletes and especially endurance athletes. And he's the former president of the American College of Sports Cardiology and the co-author of the 2025 American Heart Association updated statement on athletes and cardiovascular disease. I think we're going to look at that a little bit today. So welcome, Dr. Thompson.
Well, Jack, thanks for having me. I'm glad to be here.
Before we get into the medical stuff, kind of to establish your bona fides, I want to take you back to 1972 and the mid-70s, because you have, in addition to being a great cardiologist, an extensive athletic career yourself. Could you tell us a little bit about trying to get into the Olympics in 1972 with guys like Frank Shorter and the recently deceased Jeff Galloway, who invented kind of the walk run and popularized it?
So, Jack, I think the most important thing about 1972 is that I had hair. I had a lot of hair. But I was also a third-year medical student. And, I had run in college and I'd run afterwards. And I wanted to see if I could make the Olympic team in the marathon because I'd run reasonably well in the marathon. I really didn't think I was going to make the team. But as a third-year medical student, what I did is that I was in Boston. I was at Tufts. I always say it's where all the great ones go. But I went to Tufts Medical School, and Tufts had a relationship with the Maine Medical Center. If I had stayed in Boston during my third year, I would have had to go to this hospital for a month and that hospital for a month, and it would have been really hard to train because here was my plan. The person who won the 1970 Boston Marathon was a guy named Ron Hill from Great Britain. He won it in 2:10 in the rain, terribly cold day. But Hill was a chemist. He had a full-time job, and he would run the 10 miles from his house to his job and then run home that night. And I said, that's the way I can train as a medical student, but I've got to have one place to start from and one hospital to go to. So Tufts had a relationship with the Maine Medical Center, which is a great institution. So my wife and I elected for me to take my third year at the Maine Medical Center, and we rented a house that was 6 miles from the hospital. So I would run in and I would run out. And on the way home, there was a track. So if I had time and got out relatively easy, I could early, I could stop at the track and do my interval work or whatever I needed to do. And my wife was very cooperative. And how she was cooperative is I would call at 11 p.m. and say, Camilla, we just finished surgery. I was an observer. Can you come pick me up? And she would say, no. You're the one that wanted to move to Maine so you could run to work. Why don't you run home? So I would run home and then get up the next morning to run back. Now, I'm exaggerating that. Although, I will point out that the word for wife in Spanish is esposa, and the word for handcuffs in Spanish is also esposa. Go figure that one out. But anyway, she was very supportive, and I qualified for the 1972 Olympic marathon trials. I did not make the team. I did not think I would. I just wasn't that good. So how did I make it to the trials? Well, in 1972 was the first year they had qualifying standards. You had to run under 2:30. 2:30 is not that great of a marathon. It's like 5:50 a mile for 26 miles. I ran 2:28:15, I think it was, or something like that. And so I qualified. But I never tell anybody about the fact that I didn't think I was that good, because I really wasn't. But that was my story of, and so, that's turned out to be useful. Nothing you do in life is really not useful, but that's been useful because it gives me credibility when I have to tell athletes certain things. The thing I'm most proud about is 50 years ago this April, I finished 16th in the Boston Marathon, and that was a time of 2:29. It was 104 degrees at Hopkinton, the start of the race. And
Wow.
so and it was the only year that I didn't have night call, 1976. I was a trainee, but I didn't have any night call. So I've always wondered if I could have run better. But that's a long story of my athletic background. I always point out that, I've taken care of a lot of elite athletes. I know like what they look like. And when I look in the mirror, I don't see one. So it's a good story, but it's just background.
Well, I may have handed you a beer at Heartbreak Hill when I was an undergrad at Boston College, and would be out in 78. So maybe 2 years after your really great finish there at Boston. And just to take it full circle, personally, before we get into the some of the aortic stuff, you've been a lifelong athlete. You've 30 marathons or something like that. And I'm going to encourage everyone to subscribe to your Substack post. It's called 500 Rules of Cardiology. Is that right?
Right. So I have this blog that I write on Substack. It's free, so it's worth what you pay for it. But I do it every Tuesday, and I do something on cardiology or medicine or general, or something with respect to athletics. And it's designed for cardiologists in general, or physicians in general, but most of it is quite easily readable, because there are a lot of physician assistants, and not everybody has had all the physiology. So it's pretty down to earth. And I just wrote a series on how to take care of your doctor, for example, which was something that was really more for the general public than it was for cardiologists in medicine.
And we have aortic athletes, nerds, science nerds, who actually will find it interesting. So not everyone, it's not for everyone, but a lot of people will. But some of your more accessible things are we're going to talk about. But there was one that caught my attention, and that's last fall. You were on a 75-mile bike ride, if I'm not mistaken. Good for you. And you experienced some discomfort and had, and you write about this, had a TAVR. What is TAVR, and how are you doing? How are you feeling?
So TAVR stands for Trans-Arterial Valve Replacement, TAVR. And so, I'm 78, so I'm not a kid, but I had known for years that I had worsening narrowing of my aortic valve. And you folks out there being aortic experts know that that's the big valve that leads from the pumping chamber of the heart, the ventricle. And ventricle means stomach in Latin. So the big muscular pumping chamber, and that leads into the aorta. So mine was getting progressively narrowed. I was feeling, the current thought is that you should have them replaced when it measures tight by the echo. So mine had measured tight by the echo for several years, and I disagree a little bit with that conclusion because I was able to exercise at a high level. So on a Sunday, I rode my bike 75 miles. I went up 5,600 feet in something called the Tour of Litchfield Hills, which is a beautiful fundraising drive for the Cancer Society or the cancer care of Litchfield County in Western Connecticut. And I felt fine. In fact, I was angry with myself that I didn't sign up for the 100-mile ride. 2 days later, a tree fell across my driveway. I really live in the woods, so I got out my chainsaw. I put on my chaps. Always wear your chaps so you don't cut those thighs or your ankles or whatever. So I cut up the tree and the two trees, and I threw them into the back of my pickup truck. But throwing them into it, I kind of injured my shoulder. So I called up my orthopedic friends, and I asked one of them if he would give me an injection in the shoulder. And obviously that's steroids. And so the injection with steroids caused me to hold on to fluid, and it actually pushed me over the edge. It put me into heart failure. So I had the valve replacement about 3 weeks later. Now, how do they do that? Well, they give you numbing material in the groin. They go in with a balloon and they blow up that balloon in the aortic valve to crack it open. And on the balloon, they put the valve replacement, and the valve is all scrunched down so it can get in. Believe it or not, it can get into the artery. They can advance it up into the aortic position, and then they blow up the balloon. So they blow up the balloon, which stretches out the valve and leaves the valve in place. So I went in at 10:30 in the morning on a Thursday, and I went home at 9 a.m. the next morning, and I have a new valve. They told me not to exercise for 2 weeks, so I didn't. But then I think I rode, like 35 miles on a fairly flat course 2 weeks later, and I've been fine ever since. And with respect to you guys and gals in your habits and the sort of stuff, I'm a big believer in exercise. It helps keep you young and enthusiastic and stuff like that. So I returned to the gym shortly thereafter. You can't tell by looking at me, obviously, but I've always liked lifting weights. So go to the gym and do weights and that sort of stuff.
Well, we'll get into that in a minute. So I've had 2 open heart surgeries, and we have aortic athletes from Europe. And some of them have had not TAVR, but PARS,
Yes.
PARS. And, the first thing of newly diagnosed aortic athletes is, if I need surgery at some point, why can I only have open heart surgery to repair my aortic aneurysm? So what is PARS? Will we ever see it in the US? Is there a holy grail someday of AI and I don't know, advancement in outcomes and things where open heart surgery will be less needed for aortic dissection? What do you think?
I think all that is true. I think more and more we're learning how to fix things without having to open you up. Now, there are some instances there's no choice. You're going to need open heart surgery, open heart valve replacement, or open aortic aneurysm repair. But more and more, the techniques are being developed to do this percutaneously. So I always tell people, if you need something done and your doctor is convinced that you need something done, do it. Did I just lose all of you?
No, you're here.
Okay. If you need something done, well, then do it. But if you can put something off, in other words, your doctor says you can put it off for a while, I don't rush into, like with me and my aortic valve replacement. If I had decided to have it done, 4 or 5 years ago when I started to get tight, I might have had a very different valve put in. People wouldn't have been experienced with it. So we all complain about the cost of medical care, and it's a fair complaint. I'm not justifying, it is very expensive. But the stuff we have, the techniques, the medicines, I remember, one of the things I do is I take care of people with high cholesterol levels. I can remember November 1988 when lovastatin, one of the cholesterol-lowering drugs, was first released. Before then, we didn't have any way to, was first approved. Before then, we didn't have any way to treat people with high cholesterol levels. So, I guess my theme is the stuff we have. And going forward, I think you'll see a lot of the aortic repairs with dissections and with expanding aneurysms and stuff like that. I think you'll see a lot of it done percutaneously, as it's been doing, as some people are having it done now in Europe.
And the important message I'm hearing from you is whether it's if you need surgery, if it's time, if your aneurysm has grown, there are safe ways to address it. Whether it's TAVR, if you're in Europe, pairs, or open repair like many of us have had post dissection.
Yeah, and of course, dissection is a little bit of a different issue. That's a little tougher to do with a balloon procedure, and I'm sure your patients understand why. But when you put in the balloon, if there's a dissection between the walls of the artery, and you go in and blow up a balloon to control where the dissection started, it's like squeezing a tube of toothpaste. You can squeeze, and the toothpaste kind of goes down the aorta, so it's something that has to be done delicately, and those things are in preparation. I'm not an expert. There used to be a commercial that this guy was doing open heart surgery. I know he's doing neurosurgery, and he said he wasn't an expert, but he stayed at a Holiday Inn Express. I'm not an expert, and I did not stay at a Holiday Inn Express last night, but these things are coming and getting better all the time.
Well, in about a year ago, you were a co-author with a long list of cardiologists, including Dr. Alan Braverman from WashU, who's a friend of ours, who we mentioned, and Dr. Tim Churchill from Mass General, who we mentioned, the 2025 clinical considerations for competitive sports participation from the American Heart Association. And we, in aortic athletes, we've been talking about that statement quite a bit. And as I understand it, from talking to Dr. Braverman, there was a change in emphasis, that the earlier statements had focused just on size of an aneurysm, an aortic aneurysm, when it came to competitive athletes, and that now it seems like the approach is a little more holistic, including things like family history, syndromes, whether people have those things, but also introducing this comment about this idea of joint decision-making to the fore. So why the change? What changed for you in the 2025 statement?
For me, actually, not much. I mean, you own the body. I don't own your body. So it's always been a bit of a shared decision-making. There has been a concern that a lot of the recommendations about what athletes should do is kind of coming down from on high. This is what you should do. You shouldn't participate anymore. No, I'm not going to give you a letter to participate. You can't play in that sport in high school, et cetera, et cetera. In other words, we were making all of the decision in kind of paternalistically, or maternalistically, because there were women involved in this as well, telling athletes what they should do. There's a great move away from that. In other words, more of a shared decision-making. Here's why I'm concerned about you. If you want to take the risk, here's what you can do. Now, I don't want to pretend that I'm just an old dude, right? I'm a little cautious with the total shared decision-making in some instances, because you ask most high school athletes, let me do it this way. Why are 18, 19, 20, and 21-year-olds such great soldiers? Because they never think they're going to get killed. It's not going to come to them. So I think it's hard with some young athletes to leave the door totally open. And so sometimes I think there has to be some degree of paternalism. Now, that would get me into trouble with all my friends. But what I think you need to do is I think you need to find physicians, clinicians whose reputation and whose approach fits with yours, and then work with them in developing a shared decision making. But quite frankly, very few of you will know as much as I do about taking care of athletes with heart disease. So really, you've got to listen to some extent to what the advice is. Yeah, so I like this whole idea of shared decision making. It actually gets me off the hook sometimes, right? Because if some athlete insists on exercising and I thought they did not, and they go ahead and exercise, I'm kind of off the hook. It's much easier for me to say, no, you can't do it. Because if I let you exercise and I'm worried about you, I really face a lot of worry. And I've often said that I have what I call the Thompson "I gotta sleep too" rule. If there is an athlete that I'm worried about letting participate, or I'm worried what's going to happen to them, I either try to prohibit them or I send them to somebody else for a referral.
Well, we appreciate the worry. We don't want to overly worry you. And I also really appreciate the joint decision making. We've interviewed in the past a former very, very high level professional Ironman triathlete. He may watch this. His name is Torbjorn Sindebal from Copenhagen. And he, in his professional career, experienced some discomfort, had an incidental finding of a, kind of a borderline aneurysm. I think he had some kind of dilation. And he always said that if he was in Italy, based on the size, he would have been done. But he was, I don't know, in Denmark, they took a different approach. The long story short is 15 years later, a year ago, he had his repair, which he's recovered.
Let me tell you, I think that's an important issue because too many people aren't familiar with athletes at all, and they're overly restrictive. Because you know what I talked about that worry thing? It's much easier for us as clinicians to say, no, don't do it, right? Because then if something happens, it's your fault. I told them not to do it. So it's a little bit of a dicey situation. I've never worried about the malpractice and all that sort of stuff. I've always told people what I think they should do. But physicians have been sued for not letting athletes participate. Physicians have been sued for letting athletes participate. I don't worry about that. What I worry about is trying to do the right thing. Now, a couple comments. One is that, as your group knows, endurance athletes have bigger aortas than we would expect. The numbers are bigger for them. Tim Churchill and others have been among the first to describe this. That the numbers that we've used routinely for healthy people may be small for athletes. Now, the other thing is this. When I was trained, your aorta was not considered big until it was over 40. Now, most people consider the aorta big when it's over 38. Now, why? I don't know. It's just that we have a lot more people who are diagnosed with having an aneurysm because their aorta is 41 and they're endurance athlete. Many of those people, I tell them, look, you're going to die with this. You're not going to die of this. So I think it's important to get somebody that knows about the fact that, all the chambers in the heart are big. Let me explain this to you. So if I'm a good endurance athlete, that means one thing. I've got to have a good stroke volume. I've got to have a left ventricle that can pump out a lot of blood. Why? Because how much blood I get out during exercise is determined by how much work I can do, how much exercise I can do. So my left ventricle has to be big and strong. Now, if the left ventricle is big and strong, the left atrium has to be big and strong. If the left atrium is big and strong, the right ventricle, the right atrium, because these four chambers are in sequence and they eject into the aorta. So the aorta is going to be a little bigger. So within good endurance athlete, everything is going to be bigger. A lot of physicians, won't pick on cardiologists, but a lot of physicians are unaware of how big these chambers can be because they don't see a lot of very good endurance athletes. But just within the last to a month, I saw a highly successful marathon runner from Great Britain. I've seen the winners of multiple Boston marathons. Because if and so you've got to see these people to know what sort of changes they have. And I don't mean that in a boastful point of view. I primarily see them not because I think I'm a good cardiologist, but they think because I was a good, not great, not elite, good runner.
You were pretty good. You were a lot better than me. How do we do this paradigm shift from what you can't do to what you can do, and including our aortic athletes motto, which is don't quit, adapt? How do we make the shift?
Well, first of all, I think you need to find folks that you to take care of you, that you have trust in and faith in. Somebody that gives you the time of day. So my bias, having been an athlete, is that it's really hard for athletes to give up their sport. And so once you get that straight, it's not that hard to pick activities that are satisfied for your training, that are good for your health, but don't take unnecessary stress. Not a lot of you out there are going to go to Los Angeles for free in 2028. You're not going to make the Olympic team. Sorry to bring that to you, but you're not. So do you really need to push it that hard? There is probably some risk in extreme exertion. I think we would all agree that there's some risk. The problem is we in medicine, and the reason I think that Dr. Braverman, Dr. Churchill's study is so important, we don't have a lot of good data on what to tell you. So when we're telling you things, we're giving you our best impression. Some people say, don't do anything. I rarely do that, but I try to encourage people to find a level of exercise that makes them happy, but does not put them at undue risk, because they're not going to Los Angeles for free in 2028. So, let me just say one other thing. I don't think that a lot of you that are addicted to exercise are manic depressive. Manic depressive people are people that have really high highs when they do crazy things like sell the house or something, and really low lows when they get quite depressed. But many people have ups and downs. They have good days and they have bad days. And what I think happens to a lot of athletes, the ones that get really addicted, is that they can find that the down days are kind of eliminated by doing some exercise. So if you tell them they can't do anything, it's really, it's like saying, go get depressed. So it's really important to establish exercise regimens that people with disease, all sorts of diseases, can do to keep them healthy. Now, one other thing. When we look at atherosclerotic heart disease, atherosclerotic is narrowing of the arteries. Exercise reduces the risks, the events of atherosclerotic cardiovascular disease. But you know what? It doesn't take that much exercise to do it. In fact, here's what it looks like. Here's somebody with no exercise right up here, okay? You go down with your risk very quickly, and then it starts to flatten out. So you get a big reduction, flattens out, and there may actually be a little bit of an increase in risk way over here at the right, okay? So you can get the health benefits for your muscles, the health benefits for the heart, the health benefits from your head without, training for triathlon. Now, if you want to train for a triathlon, you can. I just always advise that most people to cut the intensity a little bit, because intensity is probably the biggest risk in all this. And then, do what makes you happy.
Well, I ran my retirement marathon in New York for the John Ritter Foundation in November, and I jogged. I could carry on a conversation the whole way, but perception and reality, for this new survey, for this new study, which is just out with Dr. Braverman, the one question was, how much time do you work out a day? I thought, let's say 2.5 hours. And it's, some of it's walking, and some of it might be jogging, some of it might be doing a couple of times a week, a little weights. I asked my wife the same question. I said, how many hours a day do you think I exercise? She said, 4. So there's perception and reality. Maybe it's somewhere in between. But I really hear you on the exertion levels, and we talk a lot about that in aortic athletes. About we know that the little science that's out there and studies seem to say that moderate aerobic exertion seems to be, it's not completely safe. We just don't know, but seems to be a lot safer based on the studies that have been done to date.
I would agree with that. I think the key issue with respect to endurance exercise is probably the intensity, because it's at the higher intensities that you have the higher heart rate, the higher stroke volume, and therefore the most stress on the aorta. But the point is, you can get a good workout, you can feel good. And also remember this, as you get in better shape, any exercise is less stress. So even though it's right after your operation and you can't do much, over time, you'll be able to do a lot more with less stress. Now, what happens? Well, as you get into shape, your heart rate's less, you require less oxygen during that same workout. So everything just gets better.
Well, we knew we were going to have this great conversation. And the great thing about having 2,000 aortic athletes is that we can quickly do little surveys and things. And this isn't, science like you're going to publish in a journal or something like that. But knowing we're going to talk about joint decision making, we put out some questions on with our aortic athletes about that. And I think, Rob, you might be able to share one of these slides. For example, we asked whether aortic athletes and their doctors mutually decided on their current exercise restrictions. And the good news is, I suppose, that about a third of our aortic athletes, and this is a self-selected group of people who are probably more focused on exercise than the typical patient that a cardiologist would see, but about a third said, yeah, they had a good, thorough discussion with their doctor about exercise. The bad news maybe is that 26% said they didn't hear anything from their doctor at all. Why do you think that is? And how do we try to improve this outcome?
I don't think they asked. When you go to a doctor, and I talk about this in How to Take Care of Your Doctor, you need to go in there prepped. You need to go in there with your list of what you want. It's very hard for me to walk out on a list. If someone's checking off a list, it's very hard for me to turn around and say, okay, see you next year. But if you've got a list, now don't be obnoxious about it. I had one of my favorite patients, and I had told him, he had met me in a group where I gave a lecture to the community about how to take care of your doctor. And so he said, I've come to see you and I've got my list. And he had one of those reams of computer paper that went all the way to the floor. He was a jokester. So don't come in with an obnoxious list that goes on forever and forever, but make sure that you go and you ask your doctor, now, what can I do? What do you recommend I can do? And things like that. So, look, not every doctor is going to watch a video or know about your aortic group on that sort of stuff. So you have to be prepared to go in there to ask the question. I'm not picking on folks. You should get that stuff done for you. But if we don't do it, you got to help us do a good job. And that's always one of my themes, My theme is I've learned so much from patients. Patients have taught me a ton. And you will teach your doctor something if your doctor's willing to listen to you. And so, go in there prepared with your questions and get them answered.
Wait a minute. The doctor's supposed to take care of me. I have to take care of my doctor.
You do.
I got to worry about her or him as well. Hey, one of the recommendations you made that I thought was so simple but brilliant is take your blood pressure every day for a week before you go in and bring the readings in.
Right. And if you're seeing your doctor for cholesterol levels or something, get your blood levels done. I have so many patients that come into me and say, well, how's my cholesterol level? I said, well, the values we have here are from a year ago. Call the office, make sure you've got the tests done. So I can kind of reel them off. I can't remember all of them. But, one of the how to take care of your doctor is don't call on a Monday morning if you don't need to, or a Friday afternoon. Now, if it's an emergency, call on a Friday afternoon, call in the morning. But, Friday afternoons, my staff and I are trying to get out of here. Monday morning, I'm digging out from the weekend. So if you can avoid those times, it's great. Come with a list of what your questions are. Come with a list of your medicines. Bring the over-the-counter stuff you use. I've had patients that are having medical problems, and it's only when I found out they were taking some over-the-counter medicine that I understood what caused their problems. Be nice to the staff. I've had people that were wonderful to me, and they would complain why they couldn't get appointments. And the people in the office said, well, the guy yells at us. He demands to have patients canceled to see us. That was actually an executive from New York City that would come up and see me. So, be nice to the staff. And then my last thing is, show a little gratitude. A lot of physicians are leaving medicine, and one of the reasons that they're leaving medicine is it said that they don't feel as if they're appreciated. You get it from the insurance company, you get it from the hospital, you get it from your patients. Show a little gratitude. Yeah, and I'm not saying gratitude in terms of a gift or whatever. Right? That's not what I'm talking about. I'm just simply saying to the staff, that you appreciate them taking care of you, and saying to the doctor, thanks for fitting me in, or something like that.
There is a thing about in the aortic dissection community about bringing brownies on your aortiversary, a year or two later to the ER. That's a good thing. I'll admit, you see my aortic athlete sweatshirt here. I have brought. You said don't bring gifts, and that's well said. But I have brought a aortic athlete's hat to my cardiologist, Dr. Vassallo at Northwestern Hospital. She's terrific. But we also asked, there's this, you're talking in a way about the psychological aspect of being nice and whatnot. On the flip side, you mentioned Dr. Tim Churchill from Mass General. He wrote an article about aortic athletes and another survey we did a while back that found that 68% of aortic athletes have a fear of exercise before they join our group. And in the current study, we also asked about, how people felt about their exercise plan. And many of them said they're still afraid. How do we get beyond the fear factor with patients so that they are exercising in a safe way and, getting at least the 150 minutes that the American Heart Association and other places a week encourage people to exercise?
Well, my advice is to start low and go slow. The idea of you mentioned Jeff Galloway when we were talking earlier. Jeff Galloway just died within the last month. He was a 1972 Olympic team 10,000 meter runner. He went to Wesleyan University with Bill Rogers, who won multiple New York City and I think 4 Boston marathons. And he also went to Wesleyan with Amby Burfoot, who won the 1968 Boston Marathon. But Galloway would recommend, running for a minute and then walking for a minute. I often start people with telephone poles. I'll tell them to jog a telephone pole and to walk 3 or 4, depending on their fitness level. And then slowly over time, just do more telephone poles. But, if you start slow, if you start low levels of demand on yourself, and you progress slowly, your body will get accustomed to the exercise you did. And if it was low level, you'll gradually be able over time to increase the intensity, but it will still seem to your body like it was still low because of that training factor. So my best advice is, and quite frankly, you're always going to have fear. You're always going to have fear. And right after your surgery, I think it's partly an adaptation. If you were a wolf and you were hunting caribou and you got speared, you're not going to continue hunting caribou. You're going to go back to the den and you're going to sleep there to heal the wound, or you won't get healthy enough to hunt caribou again. I think the same thing happens to us as humans after big operations, like an aortic dissection repair. You get a little depressed. You get like you don't feel like you can do anything. I think it's your body telling you to cool it, so you can heal the wound. But after that, that the depression can go too far. The being, and it may not be frank depression, but being down, or what I like to call dysphoric. Being dysphoric shouldn't last a long period of time. And one of the things that helps you out of it is to start that walking program. Start walking. If you're going to start running, then jog a telephone pole, but walk a bunch and then jog a telephone pole. But I think the way out of it is to do something, to take and follow the Nike commercial.
And I would add to that, we find that a little bit of peer-to-peer support goes a long way with that. So we have a lot of aortic athletes who's recently had surgery, and they hear from other people who are a month or 2 months or 6 months or a year ahead of them. And I think it provides solace that this is a journey. I call it my little by little by little patented approach to increasing endurance.
Boy, I can't compliment you enough. With social media and all of that, many people feel disconnected. And to reach out, now not everybody needs it or wants it, and some people, but to reach out to other people and to help them in the environment we're in, I think is a wonderful thing to do. So yeah, I think that's a wonderful thing to do.
Well, one last slide here about our survey. We also asked about exertion levels and what people heard from their doctors about both aerobic exertion, which we've been talking about, but maybe we can talk a minute about isometric weightlifting exertion. On the one hand, we have some aortic athletes who are told never lift more than 7 pounds. And come up with this concrete number written in stone that thou shalt never lift more than ever. And then on the other hand, we have our beloved weightlifters whose whole personality is defined by leg pressing 300 pounds, which probably they shouldn't be doing anymore. And what we found, of course, is that when people go to their doctor, if they're hearing about, they may hear something about the weightlifting. And if they do, it's usually, don't do the following, don't do Valsalva. A lot of them will hear that.
Yeah, so Jack, you're going to get me going. Okay, so let me, it's a problem. My wife says when you wind me up, I talk. She also says that one night I got up, I opened the refrigerator, I realized the light was on me, and I spoke for 25 minutes. But so let me, first of all, somebody that tells you not to lift more than 7 pounds has never been to the gym and knows what 7 pounds feel like, okay? Because I hear all these things that people are told they can't lift more than 15 pounds. Or what. Depending on how big you are, 15 pounds can be nothing. Now, I'm a tiny guy, but I do curls with 30 pounds, okay? I weigh 148 pounds. I'm a skinny guy. I've never had any muscle. So a lot of people don't know what they're telling you. So you got to be a little cautious with that. Now, the second thing is the party line that we've always told you is don't do Valsalva. Now, why? Because Valsalva increases the pressure in the chest. Increasing the pressure in the chest can increase the blood pressure. It goes up. But think about this. If you increase the pressure on the outside wall of the aorta, which results in increasing the pressure on the inside wall of the aorta, those two things press against another. So in honesty, we don't really know whether the Valsalva and all that sort of stuff is dangerous or not. Err on the side of caution, avoid the Valsalva with big weights if you can. But really, research is being planned to be done on this, because we've always said this, but it's never made a great deal of sense to me, because you got this pressure on the outside, you got this pressure on the inside, and they kind of go against each other. There are reports, and you know about them, there are a lot of them, about people getting dissections during lifting big weights. So
including aortic athletes, a few.
Yes, I'm sure. So there is some concern about it. But what I'm saying to you is get weights that you can. I like people, if they're going to lift weights, to do exercises that they can use, that they can do 12 repetitions comfortably. 12 repetitions comfortably with good form and without straining. But I don't totally totally restrict people from lifting weights, etc. We need more research on this. That's why the study by, Braverman and Churchill is such a good thing to do. We need more data.
So let's take a different group of aortic athletes, those with bicuspid aortic valves. So a couple years ago, you were a co-author of a study, maybe with some guys from some people from Holland or something like that.
Oh, the Netherlands. So
Another,
the story behind that is I had a fellow named Thijs Ijsvogels who spent over 2 years. He spent a year with me. He was on a European fellowship. He would spend 6 months with me, go home, then come back and spend another 6 months. And I got him interested in the cardiac problems with too much exercise. And one of the things I've always wondered about is whether exercise can accelerate narrowing of the aortic valve. We know that a lot of endurance exercise can accelerate the deposition of cholesterol in the heart arteries, and it can accelerate, believe it or not, atherosclerosis. Now, we all talk about how great exercise is, but as I said, on the far end of the curve, there actually may be a little increase in risk with people that are doing 6, 7, hours and hours a day of exercise. Okay. So we looked at people with bicuspid aortic valve. I can tell you it's not that conclusive, but it's an area that we need to do more study is. What's the effect of exercise on bicuspid aortic valves? Now, why is bicuspid aortic valve important to your aortic people? You're probably aware that people that have bicuspid aortic valves, very common, 2% of the population has bicuspid aortic valves. Those people tend to also have increased be at risk to develop aortic aneurysm. So that's the interest.
all right.
Jack, I can't go. First of all, I didn't look up I have 500 plus publications, and I didn't look up that one before I came in here to do this. So I can't give you the details of that article. But just to say that we didn't find anything terrible with exercise in people with bicuspid aortic valves.
Well, this is not a final exam like you in your classes, so we won't press you any further on that. But we do have I said to our group we're going to interview you, and we got a lot of questions. So I'm going to hit you with just a number of different aortic athletes questions that have come up. And we always say you can't give individual advice to anybody, and we're not going to get into that. So think of these as general questions with general answers. And maybe this is in your wheelhouse. Why are we taking statins? Why is it important that aortic athletes take statins? Because some people, some subset, have some reactions to them.
Yeah. So I had a lot of NIH, National Institute of Health money to study the side effects of statins. And basically what it comes down to is 95% of people have no trouble at all with statins in terms of muscle aches and stuff like that. Even though if you read the web seems to, social media, they seem to think that statins are killing everybody. Let me tell you something. I never miss my statin. Statins remarkably reduce the risk of having narrowing in coronary arteries. They also markedly reduce the deposition of cholesterol in your aorta. So depending on your year and age and what caused your dissection, statins, may be critical for your doing well. They're really quite remarkable drugs. So I don't know that person's present situation. I don't think statins should be in the water. They reduce the chance of having a stroke, the chance of having a heart attack by about 35%. So they're great drugs. Excuse me. And that's primarily why you're using them. I don't know many cardiologists over the age of 40 that I understand.
All right. And aortic athlete Bruce asks this question: can a person return to unrestricted physical activity after an elective repair of a non-syndromic ascending aortic aneurysm? So we get this all the time from our people. We know that I think 36% of aortic athletes had a dissection, 46% or so are in watch and wait. So this is the watch and wait person saying, if I need to have surgery, can I return? And I'm non-syndromic, no family history. Can I return to unrestricted physical activity?
So the answer to that is really your specific situation. So discussing with your cardiac surgeon, with your cardiologist. There are plenty of athletes who have had ascending aortic repairs, who return to full activity without restriction. So that is a shared decision making that I do with patients. The question is always why, because remember, you're not going to Los Angeles for free to run the marathon unless you're a lot better than I think you are. So if the question is making a shared decision, there's no absolute, in my mind, there's no absolute restriction. I don't remember exactly what the guidelines said. I was, as you know, a co-author of those new update guidelines on athletes, but I was in the coronary artery disease section, and I don't remember exactly what Dr. Braverman, who I think was the lead author there, said. But there's no absolute contraindication in my mind. Work it out with your own doctor.
And aortic athlete Della, who, by the way, is in watch and wait, she's an experienced triathlete, and she's going to represent aortic athletes at the New York Marathon next year for the John Ritter Foundation for Aortic Health. And here's her question. Would you treat a 5'2" woman with a, let's say, 4.5 centimeter aneurysm differently than a tall person with the same sized aneurysm?
So here's the answer, and then here's my questions about it. First of all, the size of your aorta, it correlates with your height. The bigger you are, the more likely more than body mass, it correlates with height. And so there's always been this push in small people, and they're often small women, and a lot of them have some, not all, but there's something called Turner syndrome. There's been a push to treat those people differently. And some of the recommendations are based on this ratio of aortic aneurysm size to it. Now, I have trouble with that approach. Why is that? Because when tension in the wall of a balloon, tension of the wall of the balloon is related to pressure inside the balloon and the radius, how big the balloon is. So if you're a small person, your height does not relate directly to the wall tension. If you're a small person and you have a 5.2 centimeter aneurysm, that shouldn't be, in my mind, much different than a 4-foot person with a 5.2 centimeter aneurysm. So really, you need an expert to deal this with you. My answer is I don't treat those people differently on the basis of their height. I use the absolute size of the aneurysm personally, but remember, I'm not the world's aortic expert.
So that's a question. So there's some discussion amongst cardiologists about whether height matters or not, and there's not yet a consensus on it.
That's right. So is there not yet a consensus? The party line is that height is the issue, and you're more aggressive with a small person than you are with a tall person. I don't totally get that. And so, I've been cautious in using height as something that pushes me faster to replace that aneurysm.
All right, aortic Denise asks, how much does maximum heart rate play into exercise limits? So I've always thought the issue for us is blood pressure, we know it's hard to get blood pressure during exercise. I mean, that's kind of something a lot of the studies and things that are happening is trying to figure out. So can we correlate heart rate to safe exercise levels?
So it does correlate, and here's why. There are two things that put stress on your aorta. It's your pressure, your systolic pressure, the top number pressure. I always remember S for superior. So your systolic pressure matters, but also how many times your aorta faces that systolic pressure. So if you have a higher systolic pressure and it happens, 60 beats per minute, That's less stressful to your aorta than if you have a pressure that's high and it happens at 120 times per minute. So they both matter. So intensity matters because intensity drives up the systolic blood pressure. The more intense the exercise, the more squeeze you've got to have. That squeeze raises your systolic blood pressure. The higher the intensity, the faster your heart rate. So they both matter. But the key thing, the intensity of the exercise, because that affects blood pressure, that affects the number of times you face that blood pressure.
And then last question, that kind of relates to the biggest complaint of aortic athletes about their meds, and that's beta blockers. I am fully beta blocked. When I ran the New York Marathon in November, my average heart rate, I think, was 110. So I was very low, moderate level. But a lot of people experience fatigue with the beta blockers. What's your take on them?
So my take on it, at moderate doses, they don't affect you that much. Now, that's me. I've been beta blocked in my lifetime as well and thought I felt fine. My heart rate wasn't as high. At the high levels of beta blocker, they will, they can produce fatigue. So that's something you've got to work out with your doctor. But, keeping the heart rate low is important because remember, that's the number of times your aorta faces that stress. So, sometimes I'm not arguing that you don't get fatigued and some people actually get dysphoric on beta blockers, a little bit more depressed. So try to find a dose that gives you good heart rate control without making it feel bad. In terms of the exercise blood pressure, you can get exercise blood pressure by just asking your cardiologist to do an exercise test on you in which they measure the blood pressure, even by cuff, while you're exercising. And that's a useful number to know for someone like you. It can also tell you where your heart rate goes too high. At what heart rate your blood pressure goes too high. And that could help you moderate your intensity. So,
and just briefly mentioned this, but that being on one dosage of the dosage of drugs can change over time. For example, I know right after dissection, I was on a high beta blocker initially, and it was understandable. They wanted to reduce the thrust in my aorta after having this surgery. And then later I was able to, I think it went from 100 milligrams of metoprolol to 50 a day, 25 and 25. And then 2 years in, the fatigue disappeared. So, I think dosages, is it not unusual, I assume, to see your dosages change like that and adapt? If it's not working, tell your cardiologist and work with them.
That is part of your taking care of your doctor to get better medical care. Can I cut down my beta blocker? Now, if you're feeling fine, don't push that. If you think you're a little dysphoric, ask. Go in there with your questions ready to get the best care you can get.
Well, Dr. Paul Thompson, what a pleasure to have you on and share your expertise. I always say that Aortic Athletes does peer-to-peer support really well, but without people like you willing to share your information and knowledge with us, we are an empty gong. So thank you. Thank you so much.
Honestly, the pleasure is mine. And, I really, we often as doctors don't think about it, but I have a lot of admiration for patients because you go through tough things and you come out the other side and you do your best to take care of you. That's pretty impressive. You don't give up, you keep pushing onward. I admire that. And if you can't handle it, it's great to have people around that you can talk to, because we only get one life, we think, and you want to make it the best you can be.
Dr. Paul Thompson, thank you so much. And remember, our motto at Aortic Athletes is don't quit, adapt. Thank you. See you next time.
My pleasure.